Good afternoon, everybody. My name is Victoria Lancey, and I'm the Rural Education Manager with the Michigan Center for Rural Health, and will be facilitating this program. First of all, I just wanted to say Happy Nurses Week to all you nurses out there. And I would like to welcome everybody to today's Nursing Grand Rounds on the vaccines updates. This program is provided by the Michigan Center for Rural Health in cooperation with the MSU College of Nursing. Before we begin the program, just a couple of reminders. If you are logged into the webinar portion and have computer speakers, you can listen to the audio through them. If you are listening to the program via the audio number provided, handouts are located on our website, and our website is www.mcrh.msu.edu. Click on the education link across the top, scroll down, find today's date, and then there you will find the presentation. Continuing education is available for nurses, and then nurses, you have a new process. Sorry about that, my phone is ringing. You have a new process, and your evaluation will be emailed to you following the program. You must complete the form in 2 weeks or by May 24th. If you would like to ask a question during the program, please type it into the chat box so you don't forget it, and the presenter can address it during the Q&A. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts, and there is no commercial support for this program. With that, I'm pleased to introduce our speaker, Kara Schrade, who is an assistant professor at the MSU College of Nursing. With that, take it away, Kara. Just a moment, everybody, and we'll begin here in just a minute. Are you ready?
I am. How are you?
Go for it.
Okay. Hi, I'm Kara Schrade, and I'm going to be talking about vaccines today. Kind of an update on why we vaccinate our population in the U.S., a little review on some of the disease states of the reasons why we vaccinate and the severity of the illnesses, and then some of the updates that the Center for Disease Control recommended this year. And so I'm going to put this right onto the share my screen so you can see the whole PowerPoint. So since the late 1700s, the prevention of infectious disease has evolved. From the eradication of smallpox, you can see there in one square where we used to give smallpox back in the 60s, to the current reduction of cervical cancer rates. Vaccines have improved public health globally and nationally, and have decreased deaths related to infectious disease. And now this slide demonstrates the number of vaccines that have become available over the years since 1964 until this year. And as you can see, as I mentioned, smallpox is no longer something that we have to vaccinate routinely for. And others continue to be added as we know more science, and then science becomes more advanced with us having the ability to follow disease patterns in those that are vaccinated. And currently there are 16 vaccinations recommended. With the introduction of the polio vaccine in the US, as well as the global population, we became quite responsive to the importance of vaccines at that time, especially in children. And if you remember, maybe from history class or even during maybe healthcare or nursing classes, that people used to line up for the polio vaccine because they were witnessing the terrible travesty that people were experiencing when they were infected with polio. There are people still alive now and in our communities, maybe friends or family that you have, that still live with polio-related weakness or paralysis. Prior to the vaccine, there were over 15,000 US cases per year, with a peak during 1952 where there were 21,000 cases. So with the approval of Dr. Salk's polio vaccine in 1955, those cases decreased significantly by 90%. The last case of polio originally acquired in the US was in 1979, though unfortunately polio has not been eradicated globally and can be imported from other countries. So the last reported case of polio was in 1993. So that is why we continue to vaccinate for polio in the US. There have been a lot of different types of polio vaccine over the years. It has changed quite a bit. The only current polio vaccine that we are using is the inactivated polio vaccine called IPV, which contains 3 serotypes of the polio, and the recommendation is listed there. IPV is contained in many of the combo vaccines that we give with the brand names of Pentosil, Kinrix, and Pediarix, and therefore the dosing and the frequency changes according to the combination vaccine we give. Because we switched from oral live vaccine to the IPV in 1987, we still aren't sure of the duration of effectiveness. We just haven't been able to see the long-term range of that effectiveness. Diphtheria is quite rare, actually. In the US, there's less than 5 cases per year. But there have been recent outbreaks globally, especially in war-torn areas like Myanmar, Bangladesh, Yemen. These places are very difficult for the WHO to get in and vaccinate, and then if there is an outbreak, for them to get in to treat. And it's very contagious. Diphtheria is transmitted through the mucosal membrane, though commonly affects the tonsils and the posterior pharynx. Symptoms usually are mild at first with a low-grade fever, body aches, kind of like flu-like symptoms. And then there's this adherent bluish membrane that is on the posterior pharynx. And at first you think it's exudates that you might be able to get off, but it's very adherent. And if you were to try to scrape off that membrane, it would bleed. After this presents, the infection progresses to severe extreme lymphadenopathy, mostly of the mandibular lymph nodes or submandibular lymph nodes, and then there's this copious nasal discharge. And I know that picture of that child is very disgusting, but that is a typical diphtheria case where there's just copious nasal discharge. You can see his swollen neck, you can see those lymph nodes under his chin. The toxin can stay localized in those symptoms, but it can cause toxemia or sepsis, which can lead to myocarditis, neuritis, blindness, paralysis, pneumonia, and even renal failure. Death rates from the illness have not changed in the past 50 years, so our vaccination rates are fabulous in the US, but we haven't improved the treatment of those that get it. And primarily that's because we're not getting into the places to treat them soon enough. Vaccination, of course, is the prevention of this, and it's been available since the 1940s. It's always given with tetanus. And the primary series is given at the 2, 4, 6, and between 15 and 18 months, then again at the 4 to 6 years. Most likely you know this, I know this is a review, but when it's a capital D, that means it's a primary series diphtheria, capital T, primary series tetanus, and then often it is mixed with a cellular pertussis, which is the A and the capital P. Sometimes something's capitalized, that's a primary series, meaning a little bit extra of that antigen. After the primary series, science has shown us that it is 95% effective, though they do recommend a booster every 10 years of the primary tetanus with a booster of diphtheria, which it would be the little d. I'm sure that you are already knowledgeable about tetanus, but I'm not going to go into that disease, but you do need to know it is life-threatening. And it occurs when the Clostridium tetani spores enter the human body through open wounds. It is the only vaccine recommended in the US that prevents a non-communicable illness. That's a good thing for, you know, if you do trivia, because it is the only vaccine that prevents non-communicable illness that we have. And like I said, tetanus and diphtheria always get given in combo. Pertussis, or whooping cough, continues to be considered endemic in the United States, with peaks reported disease every few years and frequent outbreaks. Since the 80s, there has been an increase in Bordetella, or the pertussis, mostly in the adolescent population. Though the deaths from pertussis are actually in infants that aren't fully vaccinated with the primary series. Pertussis occurs when the pertussis bacteria enters the lungs, causing swelling, preventing a person to clear those secretions. And if you can imagine that in a small child, an infant, a newborn, those airways are small as it is, and causing severe illness. That high-pitched whoop that you think of for whooping cough or the pertussis is most commonly heard in a small child. An adult with pertussis may not necessarily have that whooping cough because we don't have the small airways. The whooping, or the type of cough with pertussis, is very a violent type of cough. It causes severe fatigue in infants and children, preventing them from coughing up any secretions. Of course, if pneumonia occurs, the kids get broken ribs, punctured lungs from this illness. Also, bleeding in the brain, dehydration, and then death can occur. The issues around pertussis, or whooping cough, are pretty complicated, especially since the 80s. The U.S. switched from whole cell to acellular pertussis vaccines in the 90s. Whole cell pertussis vaccines were associated with higher rates of minor and temporary side effects, such as neurologic problems, but they were real rare. And we really don't have consistent evidence that supports that those whole cellular vaccines were the cause for these neurologic side effects. Also, the whole cellular pertussis vaccines were a bit more painful at the injection site. So they decided to switch to the acellular pertussis. And since then, there's been questioning of how long those vaccines are lasting. The effectiveness isn't as long as the whole cellular vaccines. But the cellular vaccines have fewer side effects than the whole cellular. But like I said, they're only effective for the first few years and don't provide a longer lasting protection like the whole cellular. The DTaP, capital D, capital T, AP vaccines are about 98% effective within the first year of receiving the 5th dose of the vaccine. In general, 7 out of 10 children are fully protected after 5 years of receiving that last DTaP when they are right before they go to school, the 4 to 6 years. But that begins to wane after 5 years. So the CDC is aware of this waning immunity and is investigating it further, but they continue to emphasize the importance of providing this vaccine completely as recommended according to the schedule. And providing this immunity to all of us provides herd immunity to those that are at risk and can't receive the vaccine. In 2006, the Tdap, capital T, little d, AP booster, became recommended for adolescents between the ages of 11 and 12 because of this waning immunity. And now it's being recommended for all adults who haven't received the Tdap as an adolescent. This is just a one-time vaccination. And it's given, of course, with the tetanus. So tetanus and diphtheria, which are always together. The brand for ages 10 to 64 years is called Adacel. But Boostrix is the only brand that is approved for 10 years and up. And the Boostrix are neither of the Pertussis or Tdap vaccines are approved as part of the Medicare Prevention Part B program, but it may be part of their other programs that they have on their insurance or their prescription coverage. Another recommendation to prevent illness in newborns, because newborns are the ones that get the sickest, is to give the pertussis vaccine at every pregnancy. Active immunity of the infant does not begin until 2 months of age. Excuse me. And so they're at risk if they come in contact with anybody that has whooping cough or pertussis. And you or I, if we were out in a grocery store coughing and didn't know we had pertussis, we could be infecting a young child that could die from that. So they have found that if women in between weeks of 27 and 36 weeks in pregnancy receive the Tdap, or pretty much for that pertussis component, that there's that immunity from the mother, that passive immunity that the child receives until they can have at least one of their vaccines there at the 2 months. And they have shown that this is 95% effective when we are giving it during pregnancy. This chart is just kind of a rundown, I don't know if it's helpful or not, but of what the primary series looks like and then what the booster series looks like. And pretty much it's just a repeat of what I had just said. You will notice on the left, the capital D, capital T, those are primary diphtheria and tetanus. It's not recommended to give this in this way. But if there is some contraindication and a child cannot receive the pertussis component, then they can receive the diphtheria tetanus component. Most clinics do not carry this. If a child needed that in my clinic, I would need to send them to the health department, but I would call ahead to make sure that they would have the vaccine on hand. Haemophilus influenza type B, we also call it HIB, is a bacterial infection, and it is most severe in infants. Before we had the vaccine in 1987, Haemophilus influenza type B was a leading cause of bacterial meningitis and bacterial epiglottitis in kids under 5. There were many, many hospitalizations related to Haemophilus influenza type B. Keep in mind, there are lots of Haemophilus influenza types, but I am talking about type B, which is the one that was most common for causing these illnesses. It is transmitted similar to a cold or upper respiratory infection and nasopharyngeal transmission. Children typically have to be hospitalized due to this bacterial infection. It is treatable with antibiotics, but the antibiotics the children have to receive so many antibiotics that there's been a really high resistance rate during the time before this vaccine. So having this vaccine available and preventing it has helped with resistance rates to this bacteria. The vaccine is given in 2 or 3 doses depending on the type of vaccine used. There really is only one combo vaccine that contains Hib. That's the Pertussis. Of important note, and I don't know if most people know this, that children that are unvaccinated after 15 months do have a specific catch-up schedule, but after the age of 24 months, the vaccine isn't as effective. So the Center for Disease Control does have specific guidelines for children based upon risk factors of whether or not they need to be caught up on this vaccine. Measles, mumps, and rubella, I'm sure that you know quite a bit about that already. This is just an overview and some pictures of the complications and ramifications of the illnesses. I do need to mention that there still are measles cases reported in the U.S., and most of the cases are imported from other countries. Measles is real common in other parts of the world, and because we are a globally mobile society, the rates of this communicable infection are easily brought into the U.S. The high rate of infection that you see in 2014 was associated mostly with travelers in and out of the Philippines. The Philippines was having a really large outbreak at that time. And the majority of these cases were people that were unvaccinated as well. And as you know, once measles gets into a community, especially a community that is not vaccinated, it spreads crazy. The vaccine for mumps has significantly decreased rates of illness, though in 2006, and you can kind of see the rates, how they've been going up and down, but since we've been seeing outbreaks, even in populations that have had the 2-dose vaccine series. The outbreaks seem to be occurring mostly in people that are living in close quarters or close settings. There's a thought that the mumps part of the MMR has some waning of the immunity. Though as of 2018, there's no recommendation for a 3rd vaccine of this other than the 2-dose series, but there are some recommendations for high-risk populations to receive the 3rd MMR. They're still watching the outbreaks and the prevalence of this, and I'm sure in the future we may be getting recommendations to give an additional MMR to our population. I don't have a chart on rubella because in 2004 it was announced that we no longer have an endemic from rubella. But we do, globally we have an endemic, and sadly over 100,000 infants are born with the congenital rubella syndrome, which is just a horrible syndrome. So the MMR vaccine has evolved since 1963. There are no vaccines in the U.S. that are individual monovalent for these 3. The MMR is trivalent, and then there is one that's quadrivalent, which is the MMR with the varicella, or the chickenpox, primary varicella. That brand name is ProQuad. The CDC states that providers need to assess for febrile seizures if we're going to be giving the MMRV as the first dose between 12 and 15 months. There had been some cases of febrile seizures in infants at that time when it was given with the MMRV. They can't confirm whether or not that is what caused it or not, but because of the concern, the Center for Disease Control is recommending that we at least assess the risk for febrile seizures before giving this quadrivalent, the one with the varicella. Most clinics are just because we get standing orders for the medical assistants to give vaccines, that it's just easier to just have them give the MMR at the 12 to 15 months. And then the risk of febrile seizures is very low with the quadrivalent at the 4 to 6 years for the second part of the series. So if you have ProQuad available, it is safe and highly recommended to give the combo vaccine. So hepatitis. Hepatitis B is, you know about this, it's transmitted through mucous membranes, body fluids. The most common transmission, though, in the U.S. is through the maternal fetal transmission, meaning placental or at birth. It is the second most common in the U.S. is sexual contact. Adults that get acute hepatitis B rarely progress to chronic hepatitis B. However, infants who acquire the infection from the moms at birth or during infancy are at high risk of chronic infection. Also, persons with renal failure that need hemodialysis are at higher risk of chronic infection with hepatitis B. Chronic hepatitis B doesn't typically have symptoms, though they can pass the virus on to someone else. Transmission is via blood and body fluids, like I said, and passing it through, it's very important that you know that passing it through the perinatal time can be very, very serious for an infant and have very high risk for obtaining chronic hepatitis B. And chronic hepatitis B is the most common cause of liver cancer. So liver cancer can be deadly. So it's very, there's a lot of questions about why we give the hepatitis B as a newborn in 24 hours before they leave the hospital. A vaccine that has been available since 1981, these rates have decreased of acute infection, but the chronic Hep B rates haven't decreased, so we're not getting cures. Also, I mentioned the hepatocellular carcinoma or liver failure can occur from chronic. Remember, these are babies that are most common for getting chronic hepatitis B. In 1991, routine screening of mothers for hepatitis B antigen began in order to decrease that, or at least pick up on whether or not a mom had hepatitis B so we could treat the baby at birth with the immunoglobulin. This is done in the first prenatal labs. High-risk mothers can still acquire this infection during pregnancy. And the testing is good, but it's not perfect. The testing can be falsely negative. It can be interpreted incorrectly because if you've ever seen hepatitis B testing results, they're confusing if you don't know what you're looking at. Also, it can be transcribed. They found that it can be transcribed incorrectly when the records go over to the hospital. The test doesn't pick up on the hepatitis B antigen until at the earliest 1 to 2 weeks after exposure, and at the latest 11 to 12 weeks. So a mom could test negative but actually have it. Young infants also can be infected by close contact with a family member that may have the infection. Also, the virus stays live on a surface, an environmental surface like a table or a floor for up to 7 days, even if you don't see or have any visible signs of a blood splatter. So babies can pick up on it just crawling around or being put on a floor if the virus is there. Since '92, the CDC has recommended the first hepatitis B vaccine give 24 hours after birth to healthy newborns. And then last year in 2017, American Academy of Pediatrics released guidelines to support this recommendation because the rates of newborn hepatitis B or infant hepatitis B rates have increased, primarily because there's been an increase in hepatitis B acute infections nationally due to the opioid epidemic. So this is the prevention, the vaccines. As I mentioned, the first Hep B is recommended to be given within 24 hours of birth in a healthy newborn. And it is the first of a 3-dose series. The first one is always monovalent, meaning that it's the only thing that's contained in the vaccine is just hepatitis B, and that's for the newborns. And you can see the brand names listed there. If you're only given monovalent, then you give another in 1 to 2 months, and then 6 to 18 months. Most clinics, though, are giving combo vaccines. Our clinic does Pediarix. Some people do other combinations. Pentacell doesn't have hepatitis B. It has Hib instead, but Pediarix can be given along, and it contains hepatitis B, but it also has the DTaP primary and the IPV primary, and it's giving at 2, 4, and 6 months. And so as you can see there, that would be 4 doses of hepatitis B, but that's okay. It's not a big deal for the child to get 4 doses of hepatitis B vaccine. Pediatrics combo is only approved up to age 7. So if somebody needs a hepatitis B vaccine, like if they were an adolescent, they would just get the monovalent, which is the Recombavax, which is for the adolescents. And we do not use the Pediatrix for a 5th dose. There is Twinrix, which is a combination of the hepatitis B and A for adults that would like to be vaccinated for hepatitis B and also hepatitis A. This is a 3-series vaccination. On another slide, I'll show you that hepatitis A typically is a 2-series, but since hepatitis B needs to be split between 3, the A is a smaller dose. But Twinrix is given in 3 doses after the age of 18. Rotavirus is very, very contagious. It's a fecal orally transmitted virus that can cause complications such as diarrhea, dehydration, electrolyte imbalances. There have been hospitalizations and even deaths, primarily due to dehydration in kids under the age of 5. Since the vaccine in 2006, we've had significant decrease in hospitalizations and deaths due to rotavirus. There does continue to be sporadic outbreaks in child care centers. There's even been an outbreak of it in an adult care center. It's not it's not perfect. I mean, the effectiveness is between 78 and 89%, but it's better than not having any effectiveness. There are 2 different vaccines. You can see the RV1 Rotarix or RV5 Rotatec, and the dosing, they're one's a 2 and one's a 3 dose. So if you have a child in your clinic that received the Rotatec, or you don't know what they've received, it's recommended that you give the 5, the Rotatec. And we have to give it earlier, or it's, I mean, we give it because children, when they're small, when they get gastroenteritis from rotavirus, get really, really sick. So we just give it when they're babies. So we don't begin this series until begin this series after the 14 weeks and 6 days, and the last dose of the series can't be any older than 8 months of age. We have seen that there's a really low vaccine completion rate with this, so it's hard to tell what the efficacy is really unless they're watching whether or not somebody's completing it, or are they getting the doses and then aging out. So varicella primary, which chickenpox, it's a classic picture that you can see there. Because it's a herpes virus, it can stay dormant after their first infection. I'm sure you're all familiar with varicella primary. Fever occurs, pruritic rash. Prior to the vaccine, there are about 100 deaths related to acute varicella, but mostly these were the immunocompromised children and adults. High-risk infant infection can occur if the, infants are high risk for infection if the mother is infected with varicella right before or 2 days after delivery. And these children get very, very sick, and the fatality rate is 30% if the newborn gets exposed to varicella within those times. So prevention is vaccine, of course. There's, I've already talked about the quadrivalent that's mixed with the MMR. That was licensed in 2005, approved for 12 months up to 12 years, and then the monovalent, which is Varavax, which was licensed in 95. Both of them are live attenuated virus vaccines, and they are both, you need to give 2 doses of the varicella in whatever form. It's recommended between 12 and 15 months, and then the 4 to 6 months. Primary varicella cases have decreased since this vaccine by 97% since the 95 when it first came out. And I've already mentioned about the febrile seizures, but I just want to mention again that if you're given the ProQuad, the quadrivalent with an MMR, to make sure that you screen for febrile seizures. Varicella zoster or shingles is the reactivation of varicella along the nerve route. Like I said, herpes viruses like to lay dormant, and most of the public knows this as shingles. It lies along the nerve route and is most commonly presents unilaterally. Unless someone's immunocompromised, it may be more expansive or disseminated. Pain typically occurs before the skin lesions, and the complications can be life-altering with the postherpetic neuralgia that occurs in the area of the disease, and this can be a lifetime of pain. If the lesions are close to the eye, it can affect the nerve of the eye or the ocular nerve, causing severe damage to the eye, vision loss. There have been people that have needed transplants of particular parts of the eye because of this shingles. The most at risk of severe complication, of course, are the immunocompromised. And if someone has had the primary varicella at a very young age, or fetal exposure. Prevention, of course, again, is the vaccine. In 2006, we were introduced to the first vaccine called Zostavax, or ZVL, to prevent herpes zoster. It is approved for ages 50 and older, but the CDC recommends it to be given at 60 and older, and as the one-time vaccine. This is a live attenuated virus, and it's a little bit higher virus than the varicella that's in the MMRV vaccine. They have found, though, that there is a waning protection of this Zostavax, this live vaccine, even up to 70% after a year. It really depends on the age that the person received the vaccine. To give this vaccine, there's no reason to confirm a history of someone having primary varicella, because most of the population in this age range would be tested and have positive antibodies for primary varicella. There is the second vaccine, the varicella zoster vaccine, that just came out, just approved in February. Actually, it was approved in the fall of 2017, but the CDC doesn't come out with their recommendations till February of every year. This is the recombinant zoster vaccine called Shingles. This is a vaccine that I have had patients waiting months for me to be able to prescribe because they've been following the research. It is approved for ages 50 and older. This is a 2-dose series that's given 2 to 6 months apart. It is highly effective and doesn't have the waning of the Zostavax, the live vaccine. You can give this even if they've had a history of zoster, and you can give it if they've had the Zostavax. It's actually recommended by the CDC to be given first. They would prefer you to get, it's a preference to give Shingrix over Zostavax, but that is really provider and patient preference. Both are available. The only thing, the downfall I have seen with this RZV vaccine is that there is a reactogenicity reaction that can last 2 to 3 days, which is when there's a localized immune response at the site of the injection. It can be painful, it can be red at the site, they can get headaches, shivering, maybe low-grade fevers. It's more common the earlier the vaccine's given because the immunity is higher in younger adults than it is in older adults. So of course they'd have a higher immune response. This just requires some education when you tell the patient. This is not covered by Medicare Part B. Neither of the vaccines for shingles or zoster are. It is covered by a Part D Medicare plans. So they may have a copay or a pharmacy, copayment. If they don't have a Part D, they can pay out of pocket. You can see the prices there. I do have to write this as a prescription because it is a pharmaceutical benefit on their insurance. So Streptococcus pneumoniae, there are over 80 strains of this, and they have been able to isolate a few to the most pneumonia and pneumococcal infections in the U.S. Pneumococci account for 36% of the adult-acquired pneumonia in the United States, and 25 to 30% of those persons end up getting bacteremia or sepsis. Now, since vaccinating for Hib, Streptococcus pneumoniae now has become the leading cause of bacterial meningitis among children under the age of 5 in the U.S. Children with certain chronic conditions are at higher risk for pneumococcal pneumonia, including kids with asthma that need treatment with high-dose steroids. Other high-risk adults, you can see there are the ones that are immunocompromised, smokers, adults with lung, liver disease. So what we do to prevent Streptococcus pneumonia, there are 2 pneumonia vaccines. The first one is the pneumonia conjugate vaccine 13, or Prevnar PCV 13, is how it shows up on the MICR. Children receive this vaccine. It replaced the vaccine PCV 7 in 2010. We give it as a primary series in 4 doses. It is a different schedule if they are not vaccinated before 7 months, but you can see the CDC catch-up schedule for this. In a child that is between 14 and 59 months, and they've received 4 doses of the PCV7, then go ahead and give them the PCV10. I'm sorry about that. My slides keep going on their own. I apologize. These 2 pneumonia vaccines can be confusing, so I want to make sure that I cover it well. So what's confusing really is in the adults, because the children, it's part of their routine vaccine series, and if they need to be caught up, it's very clearly written in the CDC guidelines. But in adults, this Prevnar, or PCV13, is approved for 50 and older. However, that's only for very high-risk conditions do we give it for anyone under the age of 65 that isn't a child and receiving it in the primary series. The recommendation, gosh, I think it's been about 4 years now, maybe 5, is to give 1 dose of this PCV13 at age 65. And then it's just a one-time as long as they don't have any high-risk conditions. And we need to give this vaccine 1 year before the PPSV23, which is the Pneumovax. And that's going to be on the next slide. So there are 2 pneumonia vaccines that are given to adults 65 and older. The first one to be given should be the PCV13, and then followed up 1 year by the Pneumoniavax, or the PPSV23. Like I said, high-risk adults may receive it sooner. Both pneumonia vaccines are part of the Medicare Part B wellness coverage, so you can give it in your clinic. So the PPSV23, which you most likely are familiar with in giving adults the Pneumoniavax, that contains 23 types, like the other one, and Prevnar contains 13. And it does help with the 23 types that cause 60 to 76% of the severe illness in our older adults. It is recommended to be given to adults between 19 and 64 years old if they have chronic conditions such as diabetes, asthma, COPD, alcoholism, other chronic illnesses. Anybody that has smoked, either if they're a current smoker or have a history of smoking, have a high risk of pneumonia. So it is recommended that we give that as a one-time during this age, and then we would repeat it again after age 65. But keep in mind, we're going to be giving that PCV13 as the first one, 65 years and older, and then we would follow up a year later with the PPSV23. But if they received the Pneumoniavax or the PPSV23 within 5 years of turning 65, you want to wait at least 5 years before giving it again. So I'm going to just say that again. Pneumonia vax can be given earlier due to chronic conditions. And then it is recommended to be given again after age 65. But there needs to be 5 years in between those doses. PCV13 or Prevnar is preferred to be given first of the two over 65 years old pneumonia vaccines. I hope that's clear. When you start working with it, it's pretty easy, but I just wanted to make sure that you get that pretty clear. And of course, there's always the CDC recommendation guide that I look at all the time. Bacterial meningitis is a serious condition with most cases caused by this Neisseria meningitidis bacteria. There are 13 strains, but most of the infections in the U.S. are caused by A, B, C, W, and Y. It is passed by droplet respiratory transmission. What happens is it will go into the mucosa of the nasopharynx, spread, multiply. It has the ability of crossing the blood-brain barrier into the cerebrospinal fluid, causing sepsis or meningococcemia. The fatality rate is high. Most persons are at risk are those that are living in close quarters, like in dorms, adolescents. Persons that have had a recent viral infection and then are exposed to this bacteria have a higher rate of actually being infected with it. Military recruits, and you can see the list there. And there are certain people in other age ranges than adolescents that can get that are higher, that can be high risk depending on their medical condition. The first vaccine came out in '74, but the current quadrivalent one came in '05. There are two meningococcal vaccines that prevent the serogroups of A, C, W, and Y. We know them as Menactra or Monevio. This is given routinely for the first dose between 11 and 12 years old, and then a booster at 16. The first dose, if it's not given prior to 16, then we just give a one-time at 16 and older up to age 23. Currently, most universities and colleges are requiring proof of this vaccination within 5 years of attending school to prevent the meningitis outbreaks that can occur on campuses. Remember, this is bacterial meningitis. I'm not talking about viral meningitis, which we don't have a vaccine for. Now, serogroup B, we haven't been able to vaccinate for that until the last 3-4 years. Meningococcal serogroup B, or MenB, is given in, there's two different types of vaccines, Varicella and Trememba. These vaccines are given in a different series frequency, so you can't interchange them. This really is a choice between the patient, the provider, and the parent. It is not one that's required by universities yet. It's not, or the schools. It's approved to be given between 16 and 23 years, but the preferred years are between 16 and 18, so people can have that immunity into their college years. And so the Proxera is a 2-dose, the Trememba is 3 doses. You can see the frequency there. The reactogenicity that occurs with the new shingles vaccine, the Shingrix, this MenB can cause a similar reaction and last a little bit longer, even up to 7 days. Injection site pain, low-grade fever, headache. I'll tell you honestly, I did not know that the first time I had prescribed this or ordered for it to be given. I always explained that, you know, side effects of vaccines, but I had no idea that it could last so long. So education is really important, so they don't end up getting really worried that they have an infection, or that they go to the urgent care or call you thinking that that something's wrong with them or that they've gotten meningitis because of the vaccine. You can give both MCV4 and MenB at the same time, and with other vaccinations, which is quite convenient because it's given between 11 and 12. HPV, human papillomavirus, consists of 40 different serotypes. There are several serotypes that are sexually transmitted and happen to be the most commonly transmitted infection in the U.S. High-risk types can cause cancers of the cervix, vagina, vulva, can cause cancer of the penis, can cause oral, anal cancers, and the lower risk types can cause genital warts in both genders. We do not have screening guidelines for all of these HPV-causing cancers. We do have screening guidelines for cervical cancer beginning at age 21, but only one of the 3 HPV-causing cancers are cervical. These cancers, especially throat cancer, are not detected until later in life and are very, very difficult to treat once they are diagnosed. A recent large multi-country study looked at rates of HPV-causing cancers 10 years following the introduction of the 4-valent HPV vaccine, which came out in 2006. These researchers assessed the efficacy of the vaccine if given during pre-adolescent age, between 11 and 12, and then 30 months following that age. The group receiving the vaccine early, after the 10 years, had no infections and no cancers related to these 4 serotypes. Also, their antibodies were higher than the persons that received the vaccine 30 months later. The study did have a few participants that had HPV infections with a different serotype. No cancers were found, but both of these findings led to the new recommendation of the 2-dose series to be given young when the antibodies have the ability to be higher, as well as the discontinuation of the 4-valent and the introduction of the 9-valent HPV vaccine that we now know of as Gardasil 9. It is important to remember that screening is not prevention. Vaccination is prevention. Other than the increase in the antibodies that I just mentioned when the vaccine is given early, there are other reasons that the newer recommendations for the HPV vaccination is given earlier. Between 11 and 12 years old, if you remember, we have other vaccinations that were given at that time. So it's a great opportunity to give the vaccinations all at once. I mean, we know as nurses, as people that work in vaccine clinics, that you take the opportunity when it arises. So if you have a child there that's there for vaccines, there are many vaccines that can be given between 11 and 12 years old. So that's another reason to begin it early at this age. Also, there's recent data showing that the average age of the start of sexual activity is 17 years old. This is actually an increase that children are waiting a bit longer. That's great. They have an average of 1 different sexual partner a year. So vaccinating early, again, vaccinating before sexual activity and exposure to the HPV is the most effective way to prevent the infections. So the current recommendation for the 9-valent HPV is to give a 2-dose series between 11 and 12. But if you aren't able to get that in between before 15, then the recommendation is a 3-dose series. Okay. All right, I just have a couple more slides and the rest are resources, and then if there's questions, I will open that up. I just feel the need to talk about hepatitis A since we have quite an outbreak in Michigan right now. Between August of 2016 and May of 2018, we've had 828 cases. The State Health Department has not determined the source, though there are at-risk populations that we need to be aware of, and you can see them listed. Hep A is transmitted fecal orally, and most often is in contaminated food due to poor hand washing. There is a small amount of Hep A that can be transmitted through the blood, but most cases are determined to be fecal oral. So prevention, again, is vaccination. Children, the newer guidelines for the CDC they're now recommending that children 19 years and under receive a 2-dose series of hepatitis A, 6 to 12 months apart, and then those that are at risk at 19 and 18 years and older can receive it. One thing I want to emphasize is that there are two. There's the Havrix and the Vacta. I've never given that, so I don't know how you say it, but Havrix. They come in different doses, but the pediatric dose for both of them is considered pediatric up until 18 years old. So it is something that's been an error, that people are giving an adult dose to an 18-year-old and should not be doing that. The pediatric dose, the 720 for the Havrix, is needed to be given up until 18 years old, and then at 19 you can choose the adult dose for them. I've already talked about the twin Rix combo. During outbreaks, it's priority that we at least give one dose to people at risk, because it is up to 95% effective within a month of one dose. There are guidelines at the State of Michigan website, Department of Health and Human Services, on how to treat if there is an outbreak or an exposure. So I won't go completely over all of that. It's right there on your slides. I just wanted to give you resources. I mentioned that the Pentacell has a different schedule than giving vaccines with Pediarix schedule. So I've gotten this from their company's website. This is from the GlaxoSmithKline website for the Pediarix. Lots of trainings with the Center for Disease Control. They're amazing. Much of my information today came from some of these. So I recommend you look at these, especially if you have a great interest. A lot of them have CE credits available. The approved vaccines change from year to year. This is a link to the most recent. And I'm not sure if you're aware that a lot of vaccines do contain small amounts of latex, depending on what their packaging is. So if someone's highly allergic to latex, you need to be aware of that and to have a resource to look at to see which, either the syringe or the vial. It just depends on the vaccine. If you don't have this app, I highly recommend it. I use it all the time. It's interactive. You put in the age, and it tells you what vaccines the child would need. These are some other resources from the Center for Disease Control that you can use to talk with parents about vaccinations. Education is key. Even anticipatory guidance can help for the next visit. And more materials. These are resources for adults. This, what vaccines do you need, is an excellent little quiz, and it helps adults be active in knowing what vaccinations they need based upon their risk factors. It's an interactive quiz. I have put it in some newsletters for communities for adults to go and take that. And then those are my references, and I will come out. Sorry, I went over the time.
Oh, that's okay. I'm going to open up the lines for some questions, and we'll go from there. So lines are unmuted. If we have any questions, our speaker will be more than happy to answer some questions. I have or you can feel free to type it into the chat box.
Okay.
And I can read them through there. I do have one question here that says, if you have a patient that is repeated cancer, a repeated cancer patient, what would you tell them to, and they want to get a shingles vaccine, what would you tell them would be an appropriate response to them?
Yeah. Well, it depends on whether they're getting active treatment. If they're getting active chemotherapy, then neither one is appropriate at this time. They are saying that in the future, the newer one that's not a live vaccine should be okay for those that are immunocompromised, but currently they are not recommending that, but definitely no live vaccines. They do recommend the non-live vaccine if somebody is about to undergo chemotherapy to get it prior to them becoming immunocompromised.
So
of course,
if they're in recovery, if they've been in recovery, then it would be okay?
Yes, if their immune system is okay, then. Leukemias and lymphomas, many of them are still immunocompromised. And
right.
I would wait, I'd wait until the literature comes out more on that one. So currently it's contraindicated, but from the literature I've read on this new Shingrix, they anticipate it to be safe. But currently they're not recommending until
more studies.
More studies, yep.
Okay.
Yep, good question.
Are there any other questions or comments?
Well, I have Kathy Forrest sitting here with me to give me support, and we both say Happy Nurses Week to all of you and those that support nurses. We appreciate you.
Okay, great, thank you. I just also wanted to say it was a great presentation, and I thought it was very interesting. I got a lot out of it. Just myself, and I'm not a nurse, so.
Well, good. I'm glad.
Yeah, I would second that. I agree. It was very, very informative. I appreciate the answer to the question on the oncology history. Good presentation.
Great. Great. I'm glad you enjoyed it. Please share the information and all the resources there. The CDC has so much to offer.
Okay. If we don't have any other questions or comments, we'll go ahead and sign off. I did record the webinar, so we will have the recording if anybody would like it. I will email that out to you.
Yeah.
Thank you and have a great day.